Lee, I have to tell you, I'm a collector of medical literature, and I'm up to 67 different human chronic conditions, everything from Parkinson's disease to intimate partner violence, where there are peer-reviewed publications saying that plant-based eating is better for you. So anyone who is saying that LDL is not associated with plaque, not associated with plaque rupture, is really not looking at cardiac events and LDL in a serious fashion. And by serious, I mean, put it in a search engine, LDL mortality, and then click images, and you'll see all these graphs where it's almost a linear relationship. Deathly afraid. I'd refer everybody to the March 7th New England Journal of Medicine this past 6 months ago, where they elucidated the issues with microplastics and nanoplastics. No, we have polluted the oceans to the point where we shouldn't be eating anything that comes out of the ocean. By the way, I just say it publicly, for those of you who have not seen the Panther trial and all the subsequent studies, we try not to use aspirin anymore. It's just another one of these things that we had wrong for 60 years.
Welcome to the Kurisko & Company podcast. I'm your host, Dr. Lee Kurisko. We are honored today to have as our guest Dr. Kim Williams. Dr. Williams is a cardiologist based out of Louisville, Kentucky, formerly affiliated with the Rush University Medical Center in Chicago. He's a fellow of the American College of Cardiology and served as its president from 2015 to 2016. In 2003, Dr. Williams became vegan based upon his interpretation of the medical literature. He had great success lowering his cholesterol by eliminating animal products from his diet. Dr. Williams is an icon in the plant-based world and is famous for the following quote: "There's two types of cardiologists, those that are vegan and those that have not reviewed the medical literature." I hope you enjoyed this interview as much as I did.
Sure. Welcome, Dr. Williams.
Well, thank you. Thank you so much for having me.
So back in 2003, when you rocked the boat and became vegan as a cardiologist, I understand you had some pushback. How was it received? How well was that received?
So the pushback continues, mostly from the keto world, thinking that people should eat high protein, high saturated fat to improve diabetes. It actually started to upset my vegan colleagues, but it does improve diabetes. It can actually lower blood pressure because it lowers weight. The problem with it, which anyone can find out just by putting it in a Google search or ChatGPT, just put in the words keto diet mortality, and you'll see that even though you're lowering some cardiovascular risk factors, the increase in the LDL cholesterol and the increase in inflammation that happens when you ingest, hate to be gross on a podcast, but ingest carcasses, that inflammation results in more heart attacks and higher mortality. How much it goes was all over the place. And so people didn't believe it. It can't be 13% increased mortality and 71% mortality. And then Sarah Seidelman about 3 years ago published an article showing you that there was a linear relationship. And the reason all those populations were different because they were doing different levels of low carb diet. And the more you do, the more dangerous it is. And so the pushback got sort of pushed back during COVID, where the articles were very clear that if you have a wonderful plant-based microbiome in your GI tract, you didn't get cytokine storm, and you could get COVID, but you wouldn't get very sick with it. And people were saying no vegans died of COVID. That's hard to imagine just because there are some bad vegan diets, particularly refined grains, sugar, and the like, fried food. But I don't have any data to refute that, but clearly large studies showed that there was dramatic decrease in the degree of illness that people would get with COVID, and even a 40% decrease in incidence. Okay, now I have to say, every time I quote that, I'm always a little skittish because there's an observer bias there. If you get COVID and you don't get sick because you're vegan, how do you know somebody else know you had it? So that 40% decrease in incidence might be underestimation because people are completely asymptomatic. We all have viruses. We all have things going on. And if you're not sick, how would you know to get tested? The authors said they controlled for it, but 40% less. So anyway, bottom line is it's a healthier way to live if you're going to live through a pandemic. And we'll see what happens if we start to get the pushback back. But at this point, Lee, I have to tell you, I'm a collector of medical literature, and I'm up to 67 different human chronic conditions, everything from Parkinson's disease to intimate partner violence, where there are peer-reviewed publications saying that plant-based eating is better for you. And what does it have to do with violence? Well, it turns out that when you're eating the hormones, and this was not put out, by the way, by some vegan group. This was put out by a buffalo meat company, and anyone can go do an internet search and see it, that let's call it, I'm looking for nice euphemisms here, preparing the cow or for the beef, what they go through, does an adrenaline, norepinephrine, dopamine surge. It's actually in the meat, and people are eating it, and it changes their behavior. That's the theory. There's actually a lot of literature, about prisons and college students, and it's actually quite remarkable. So we have, in addition to that, the usual things like hypertension, diabetes, high cholesterol, a bunch of skin disorders, a bunch of rheumatologic inflammatory disorders, all of which get better. The one that I added yesterday based on one of our teaching conferences was hepatic encephalopathy. You stop eating animal products and your ammonia levels don't rise. So that was a recent publication. I think the study needed a larger population size. They didn't think so because it reached statistical significance, but you won't get into anybody's guidelines with a study of 10 people. So I think it does need more, but we could just go on and on and on outside of cardiology, talking about the beneficial effects that I adopted for my cholesterol, and it turns out my aging slowed down. So that was also shown. Telomere shortening slows down when you are plant-based.
Yeah, I mean, we're totally sold on it. I went plant-based in 2017, and my cholesterol dropped 187 points.
Wow.
Yeah. Amazing. So I was totally sold on that. Yeah, I'm really glad that we have you on, because it's really common on the internet these days to sort of disparage that whole cholesterol, saturated fat, heart disease hypothesis. There's a lot of misinformation. They'll glom onto the perception that Ansel Keys, when he did his 7-country studies, sort of used bad data, cherry-picked the data and that sort of thing, which I believe is actually not true. There was sort of a paper refuting the so-called debunkers of the 7-country study, dealing with all those objections. I think he was probably a great scientist. And my understanding is that the data linking saturated fat, cholesterol, and heart disease goes back over 100 years. So do you have any comments on that? Like, what is the rationale for saying that that is just not true, that saturated fat is not an issue? Like, there are people on the internet just saying, just completely ignore it. Don't worry about your cholesterol. I find that horrifying.
Yeah. So what I would recommend is that anyone who has concerns about it looks at the density of data. And people will say, oh, it's all pharmaceutical industry. Well, if you throw out the things where there would be pharmaceutical bias, like I'm just going to pick a couple of them, asteroid trial, where the Crestor people were trying to throw Lipitor under the bus, and it came out the same. That was not a bias. That was a cold market-changing admission because they thought they're going to take over the world, and they came out the same. And what by the same I meant plaque regression associated with a dramatic lowering of cholesterol. It worked for both drugs at high doses, not at moderate doses. And that has to do with how low the LDL got. Another really good one would be to look at the TNT trial, which was high dose Lipitor versus low dose Lipitor, and high dose won, similar to the asteroid trial. And that's not, industry, that's because they charge the same for both. So this was just pure science, not industry profit driven. But if you look at all of it, it doesn't really matter how you lower. I mean, we'll go back to Greg Brown before we even had statins, and we were using stuff like niacin and fibrates and all this stuff. You could still see some plaque regression if you got your LDL low. So anyone who is saying that LDL is not associated with plaque, not associated with plaque rupture, is really not looking at cardiac events and LDL in a serious fashion. And by serious, I mean, put it in a search engine, LDL mortality, and then click images, and you'll see all these graphs where it's almost a linear relationship that continues through zero, kind of like, when you get below 40, and that hasn't become our target yet, but it probably should be.
Is that right? That's really low. That's really low. I mean, my LDL went down to 83, which is much better, but it's still not totally ideal. Now, one criticism that you see, people will say the statins require too many people to treat to prevent a single heart attack. for both primary and secondary prevention. What are your thoughts on that?
So, well, I would say that statins are one of the major issues. And if you follow people long enough, people have events and they die. So you end up, if you start with an older population, it's harder to see the differences because people are dying of a variety of things. But there's really convincing evidence on decreasing heart attack, stroke, peripheral artery disease, limb ischemia with amputation, and actually good convincing data, although not as much, on cancer reduction with statins. And so I would encourage anyone to just read the literature and be guided. Now that we have AI, you can just put it in your AI and say, hey, what about statins and mortality? And you'll see all this stuff come up in a very convincing fashion. Probably the biggest concerns, there's two major concerns about statins at high doses particularly. One would be that it tends to make people who are pre-diabetic diabetic. Well, that we have the solution to that. I'll get back to it in a second. The other one is increasing Lp(a). We have for people who are statin intolerant, we have drugs, the PCSK9 inhibitors, that actually lower Lp(a), but they haven't decreased mortality any more than the statins do. And so we're saying, hey, it increases Lp(a), but it still seems to stop heart attack, stroke, death, and cancer. So maybe the Lp(a) is a marker of risk that when you start to modify it, and we're going to find out because there are 4 different trials going on like that, 2 phase 1, 2 phase 3, we will find, and they all dramatically lower Lp(a) levels. Does it affect mortality at all? We'll find out. But right now, we know that affecting the LDL and the C-reactive protein, inflammation, which you do with statins and with a plant-based diet, dramatically improves the cardiac outcomes. So I'm switching to the plant-based diet because statins are great, but we have a bunch of my vegan doctor colleagues saying don't take statins. And I think they're backing away from that because they see too many episodes of people needing both, particularly if they start when you or I did, a little older in life. You need to get rid of the plaque that you have. And the best way to do that is get an LDL less than 55 or so. And the best way to do that is both. And so in the infamous words of Neil Stone, my colleague in prevention at Northwestern, and he actually put this into our journal, which of my arms do you want me to cut off when I'm trying to help give you a helping hand? Which are you going to, ignore the statin? Or the much larger group is traditional cardiologists prescribing statins and never saying a word about plant-based nutrition and not adopting it themselves. So we've got some issues.
Yeah, that's sort of one of my pet peeves is that this isn't brought up in general medical practice, yet it's an incredibly powerful tool. I'm glad you mentioned the LPA. That's actually a great personal concern for me because despite eating a high quality plant-based diet, my LPA is about 3 times the upper end of the reference range, which is concerning. I had a consultation with a cardiologist a number of years ago, and although my lipids were really quite good, she actually recommended I go on a low dose statin, but I was reluctant to because my father died of a myopathy that might have been caused by taking the statin. So I just have this reservation.
Peripheral myopathy.
Yeah.
Not cardiomyopathy.
No, like a peripheral myopathy. Yeah. He had inclusion body myositis, which may have been due to that. We don't know for sure.
It would be rare, almost unheard of, but anything can happen to anyone. But let me just say, if your doctor is listening, is that in 2019, ACC, American College of Cardiology, and American Heart Association, we put together the primary prevention guidelines. And it really says that there's a big role if your cholesterol is high, if you've got any risk factors, is to use the ASCVD risk calculator, which is now morphed to the Prevent calculator. And there's several calculators out there. But if you have more than a 7.5% 10-year risk, you really should get a coronary calcium score because that really refines your risk. So that coronary calcium score will say, and this is quoting the MESA trial, if it's negative, 0 calcium, you're like cardiac immortal for a decade. Not exactly, but pretty close. If it's mildly abnormal, you really do need cholesterol therapy. You try to get your LDL down really low, particularly usually with a statin. If it's a score above 100, it's not mild anymore. That's when you start using antiplatelet therapy. And I think most of us in the room for that, we kind of agreed, but didn't put it in the document because there just wasn't enough evidence, but it was more like clinical practice. If you get the score that's more than 300 or 400, you probably should have either a stress test or CT angiogram or something further to make sure you don't have the dreaded left main disease or proximal left anterior descending. And that's a good practice. So that's when we use the statin, is based on testing. So if she thinks statin, the answer is do the calcium score.
Yeah, so that you raised the thing about the risk stratification. So it's no longer just about the raw numbers. It's about risk stratification.
That's so important. I know personally that LDL came down dramatically, and I was really proud of how much I was doing. Always was exercising, focusing on that and diet. And despite being African American and despite being male and over 60, I still had a low CVD risk score. Fortunately for me, I got really sick, food poisoning, about 2.5 years ago. The bean burrito that saved my life, probably. I ended up in the emergency room. The pain got so bad, I thought I was going to die. And then the pain got worse, and I was afraid that I wouldn't die. So I asked them to do the coronary calcium or do the abdominal CT, which they agreed to do. And then when I got in there, I asked the tech to just go up to the carina so I can see. I got a coronary calcium score of about 30-ish. And so I started the statin back then and got it down. It took a lot of refinement, particularly for those of you out there trying to get your LDL down. Don't forget, it's not just animal products, it's refined grains, saturated fat, just like the literature says. And so when I eliminated all of those, changing the white rice to black rice, if you haven't had forbidden rice, you should try it. Then I could get my LDL way below 55. But it's hard work. You have to be very intentional about it, recognize what the risk and the benefits are.
Yeah, that's interesting. Now, regarding the calcium score, now my understanding is if you adopt a plant-based diet or if you go on a statin, tell me if this is true or not, that it can actually cause the calcium score to go up because you're stabilizing the plaque. Is that correct?
You got it exactly right. And so I know I run into so many people who say, well, doc, I just want to see my calcium score again. And I'm saying, why? If you do nothing that I ask you to do in terms of plant-based diet, exercise, stress reduction, using a statin, I mean, if you do none of it and your LDL stays high, your blood pressure is off the charts, your calcium score is going to go up because you're getting more plaque. If you do everything I ask, what's going to happen is the soft plaque is going to go from fatty plaque to fibrofatty, that is getting some scar tissue in it, then from fibrofatty to fibrous, from fibrous to fibrocalcific, and finally calcified, stable plaque that'll never hurt you, okay? But it'll show up on a calcium score. And so it's going to go up either way. And the question is, well, what do you do about that? There's a fair number of cardiovascular radiology, CT gurus who say that is the weakness of the coronary calcium score. It's good for initial risk stratification, but probably everyone should have a CT angiogram. And we haven't quite gotten that far in our guidelines. The data on CT angiography is so robust, it won't be surprising that as we go further into this, that our guideline for disease management will have CT at the core. For something I said a few minutes ago, you really want to measure that. You want to find out if you have left main and proximal left anterior descending disease, and the CT is a quick and easy way of doing that.
So a number of years ago, I did in fact have a calcium score and I got a CTA, and I had a calcium score of about 120, which is not great. I'd been on the plant-based diet for, I don't know, about 4 years at that point. Yeah. But the CTA showed no stenosis. So obviously there'd been some wall remodeling. So what you're saying, probably I've had that one calcium score, I probably shouldn't look at it again. Is that a reasonable statement?
Well, so you probably recognize that I'm speaking, on two different sides at the same time. That is, there's limited value of repeating it because it's going to go up. But yet I'm saying higher scores get a test. Well, fortunately, you already had the test. And so I'm not sure it applies to you, but that distance, that difference of using a whole food plant-based diet, an exercise program, mindfulness, statin, and antiplatelet therapy. By the way, I just say it publicly for those of you who have not seen the Panther trial and all the subsequent studies, we try not to use aspirin anymore. It's just another one of these things that we had wrong for 60 years, just because the agents, that's prasugrel, Brilinta, and clopidogrel, are just safer. They also are more effective by a hair, but they're safer, less intracranial bleeding and less GI bleeding. So, it's that doesn't seem to have caught on. People are still, well, they're still eating animals too, but they're still using a lot of aspirin. And we use it as dual platelet therapy, but after that stent, you're going to be better off dropping the aspirin than dropping the Plavix. So anyway, that whole thing of once you're above 100, doing that means that there is some value of doing a repeat. If I was in the 90s, I would definitely want to have it done in 5 years to see if I was above 100. And I should go on an antiplatelet drug.
As far as LDL and HDL, is there merit in them being fractionated into their density? And first of all, is HDL a legitimate protective effect, or has that been debunked? And is there merit in the fractionation of the LDL to stratify, the large buoyant versus the small dense particles?
So HDL, another thing that we had wrong for the last 60 years or so, actually still has value, but its value is very limited. And I hope everyone in the sound of my voice will just go into your search engine, hit HDL mortality, and click on images, and you will be stunned at the U-shaped curve. And how many drugs did we use? The fibric acid derivatives, the niacin, where we didn't get the results we were hoping for raising HDL. And that's because raising HDL is apparently dangerous. And so the reason that it still has value is that very low is high risk, very high is high risk. You want to know that you're in the middle. Now, what do you do with that information? That's not clear. Exercise is really good for it, and it's probably safe because it lowers the LDL. And the statins, you do get, particularly with Rasuva, you get a little bit of increase in your HDL. That seems to be safe because you're lowering the LDL. And so, I just use it now as an additional risk factor when it's in the 30s or in the 90s or above. You need to know that person is at risk and really try to get that LDL down. That hasn't gotten into a lot of our calculators yet, but because it's relatively recent, it was the CAN-HEART trial and Copenhagen studies that showed the danger of having a high HDL cholesterol. So I'm hoping that becomes democratized. Everyone needs to know that.
Yeah, I mean, there's a common conception that, the higher the HDL, the better. So it sounds like that's not actually true.
Not actually true anymore, like much of cardiology. Not true anymore. Okay.
Now, what about ApoE? Is that something that we should be getting measured routinely? Does it trump the other parameters, or is it necessary to be a routine test?
Okay, so two different things, and they're both important. One is ApoB. I think that's what you're talking about, the lipid fraction that is similar to, but maybe a little bit more powerful than LDL in predicting outcomes. When do we use it by guidelines? We use it in that I mentioned above 7.5%. What I didn't say is that between 5 and 7.5%, we do try to use ApoB, small dense LDL, C-reactive protein, okay? We probably should have data on trimethylamine N oxide from Cleveland Clinic, TMAO, but we don't just yet. CKD, lupus, rheumatoid arthritis, positive family history. That's 7 of them. There's a total of 14 things that in our guidelines that if the patient has them, you kind of consider them above 7.5 if their risk is 5.5% 10-year risk of heart attack, stroke, and death. So that really is the value. That says, yeah, we better go ahead and do that calcium score or start that therapy and try to get the LDL down. Now, the ApoE, that is an allele that's really important. It codes for a little bit better athleticism, but the ApoLE1 or epsilon 1, it turns out that it's important for the development of chronic kidney disease. And hopefully every academic center should be developing a cardiorenal clinic like I've tried to do. The idea is that we've got some huge healthcare disparities in this country. A lot of it is mediated by kidney disease. Our African-American population, we are 12% of the US and 35% of the dialysis patients. And we have a high prevalence of that ApoL gene. And so that really needs to be, if not measured, modifying the way we do things. It turns out that the big cause, and the reason I'm talking about it so much, is that it's animal protein. And if people don't believe me, just type in the word CKD animal protein, and this massive, largely ignored literature is going to come up telling you that no one with chronic kidney disease or the risk factors for it should be doing anything other than plant-based nutrition. Not coming from the editor of some rogue vegan journal, that's me, by the way. It's coming from the National Kidney Foundation. Avoid animal protein. It's actually coming from DaVita. Why would DaVita care if they're doing dialysis? I don't know. I haven't talked to them, but I can tell you there's so much information on the DaVita website about this. I can only figure, wait a minute, if somebody's on dialysis and doing plant-based nutrition lowers their BU, lowers their creatinine accumulation, lowers the degree of metabolic acidosis, lowers their phosphorus level, that they're going to get that person out of the chair in 2 hours and put somebody else in there. And so maybe it's just financial, but it definitely helps the people's health, regardless of what their motivation is.
Yeah, I'm sure that there's some financial motivation. I don't think the average physician has any idea that there's a link between animal protein and kidney function, which it's unfortunate. I mean, I think there's just a general lack of knowledge, which part of Joyce's and my mission is to try to educate people. We've started giving talks, and we want to target one particular talk specifically to local physicians, because I think the awareness is incredibly low. Some of them are advocating ketogenic diets for people, which, we're not fans of. Now, a popular buzzword these days are seed oils. Even RFK Jr. talks about the perils of seed oils. Is that based in fact? Do we need to worry about these seed oils?
So there's a small amount of literature, often quoted by, Caldwell Esselstyn, for example, the no oil plant-based diet. And there's some other no oils. John McDougall just passed away a few months ago, but he was a big high starch, no oil. I think T. Colin Campbell would fall into that category as well, having spoken with him about it. What I think very simplistically and maybe oversimplistically about it, yes, there is a Vogel study on vascular reactivity saying that acute doses of oil tend to impair arterial flow. That doesn't seem to be true of olive oil because of its polyphenols. And when you look at outcome studies with olive oil, canola oil, and avocado oil, they actually do really well. Now, what's the unifying feature there? High degree of monounsaturated and polyunsaturated fat and very low saturated fat and no trans fats, okay? And so that goes along with the literature. Saturated fat increases mortality. The more you eat, the more you die. The more of the other two, the lower the mortality is. And there's a saturated fat American Heart Association president's page from a few years ago that goes through all of this data. And so the seed oils, you have to look at each one and how much saturated fat is there. And if it's a lot, that's one that I would avoid. How much is a lot? If you have more than, I draw the line personally, having done, back of the napkin calculation at about 3 grams of saturated fat per serving. Below that, it doesn't seem to bother my cholesterol personally. And above it, it starts to creep up. But the American Heart Association position was no more than 10% of calories. If you calculate your calories, you're probably going to come out around 3 grams, being 10%.
Well, I think one problem with the oil in general is it's so calorie dense, which is a problem with so many people being overweight.
Yeah, and you're absolutely right. And so you're absolutely right. I really should emphasize that I love prescribing the Esselstyn diet because I'm now in Kentucky. We are not the most obese state, but we're in the top 10. And the differences between number 1 and number 10 is about 2 pounds.
Was that right?
We're up there. And so there are very few states where the Caucasian population is more than 35% overweight, and we are one of them. And obviously we have an African-American population here in Louisville that struggles like the rest of the country does in terms of it's not just obesity in African-Americans causing diabetes and the like. It's actually mortality. That whole idea of fat and fit, or the obesity paradox, does not apply to us. And we have to understand that we all need, if you have it risk, and that is, it's not just blacks. It's in Kentucky, it's Appalachian whites. It's all of our South Asians, including the doctors, who are actually at extremely high risk. We all need to be doing a whole food plant-based diet, getting rid of any obesity, particularly central obesity, exercising every day. And we do that, we'll do just fine. And we'll protect our society from the escalating toxic costs of healthcare. So why is everyone so worried about our Medicare system and with the new administration and what's going to happen? Well, it's because of our lifestyle. And the care here is very expensive, but it's the best care in the world. We have some of the worst outcomes of any developed country, but the care that we give and the developments that we have are tremendous. And it's a capitalistic society. Therefore, people have to pay, supply and demand, high prices for good things. So we're keeping our older population alive longer at very great expense, while we're suffering from premature death of our middle age group and the opiate crisis. You throw that in with some fentanyl, and we're losing our tax base at the time when the older people who you don't live to 80 years old doing fentanyl. So you figured out how not to do those things, but you're not contributing to the tax base anymore. And so that's a problem that's easily solved. American College of Lifestyle Medicine, I'll give them a plug here, has the 6 lifestyle principles where you develop good relationships, you have a loving environment, you don't do any substances, you exercise every day, and a whole food plant-based diet. If you do all that stuff, all of our financial problems in this country would actually go away with regard to healthcare. And so I'm not saying that you're not patriotic if you're not doing ACLM 6 pillars. Oops, I think I just did.
Well, I mean, yeah, I 100% agree with you. And it's on my to-do list that I want to get that certification. I think it's a good thing to have. Just by the way, what prompted your move to Louisville?
So after this, I was never wanted to be, it's actually a long story, but I'd be more than happy to talk about it because it talks about healthcare disparities. In my background, growing up on the south side of Chicago, not having access to good care, so I decided not to be a slough-off student anymore and try to go to medical school. I got into college at the University of Chicago, a little bit of a rough transition from Chicago public schools to the University of Chicago, but I made it with a lot of hard work and a lot of tennis. Funny part about it is that after 4 years of the life of the mind, medical school was not a big transition. It was hard work, but it was not a tough transition. Did okay. And then I ended up at Emory for internship and residency, where the whole program was about cardiology. And so I did my cardiology fellowship back at University of Chicago, teaching my faculty how to do clinical cardiology, because I had been at Emory and they hadn't. They were mostly basic science people.
Yeah.
And so there I was on the south side of Chicago. I developed the nuclear cardiology lab. That was my interest. And everything was going well until about 24 years in. I made it to full professor and everything, president of the American Society of Nuclear Cardiology. U of C was one of the most productive nuclear labs in terms of research and publications and clinical quality. And they said that we couldn't see poor people anymore because they were building a new hospital. And it was really tough to work there. And anyone who was a minority and concerned about health inequities had a hard time working at University of Chicago 2008. I tried to stick in there because, as I mentioned, I'm basically a maroon. I mean, those 3 years at Emory, but other than that, all of my training, all of my everything was University of Chicago. And it's on the south side, and I was taking care of my inner city population. Anyway, it got really a toxic environment and anti-people pushing back on trying to see poor people. Ultimately, they were asking me to be chief of cardiology at Wayne State, and I had turned it down about 3 different times. And when this came to a head at University of Chicago, I took the job, as long as they promised me I'd be able to see poor people. Well, the problem at Wayne State was, you could see poor people, there's nothing else but in Detroit, but they didn't have the resources to help them as much. So, you're kicking against the goads, as the scripture would say, and you're doing the best you can, but you don't feel like you're getting anywhere. And 2 jobs opened up in Chicago after I'd been in my 4th year of chief of cardiology. One was Rush and one was University of Illinois, and ended up with the Rush job really because they sent me the offer letter faster. So I come in, the program's got some disarray to it, but some really talented people. I took all my old University of Chicago fellows who were just amazing people, contacted them to see if they were happy in their jobs. And this is how I got a reputation as he for she. I hired all women. Why? because the women were unhappy where they were. Silly things like, I need to get my kid to school at 8:15, and they're saying if I don't start my clinic at 8 o'clock, they're going to dock my pay. Well, I'll start your clinic at 9 o'clock. Okay, just whatever you need. And so just doing simple leadership things. We got the faculty built. We built a broader base. And with the help of some improvements on the surgical side, we went from unranked to number 50 in the country, number 35. And by the time I left 9 years later, 2 weeks after I left, which means that it had already been taken care of or voted on, we were number 15 in the country in cardiovascular medicine. Well, that's during that really transition, impressive. I also was ACC president. And so a lot of people were asking me to be dean of this and chief of that and president of the other. There were a couple of them that I was really tempted. One of them, I really kind of think about, Wisconsin Badgers. It was such a wonderful institution, wanted me as chair of medicine, and I ended up turning it down because there wasn't a lot of minority health that I could do. Obviously, I could try to influence nutrition, and those are two things I wanted to do: nutrition and minority health. There were other places where I could do minority health, but I couldn't do nutrition, and back and forth. And I got to Louisville and did this interview, and it turns out that it was a wonderful conversation with wonderful people. It'd been through a lot, and they were in a rebuild, and I'm good at rebuilding. That's what I do. And when I said nutrition and inner city care, they actually were very excited about it. It turns out that University of Louisville and University of Kentucky Wildcats, we get extra money from the state for taking care of the poor.
Wow.
Medicaid supplement is so rich that they just wanted somebody who would actually go to the West End and get the people to come here, which is what I do. And so that, it's a wonderful opportunity. It's a wonderful institution. There are areas where we could do better. The education is improving. The basic science research was always strong, but the clinical research, like we were doing at Rush, was less developed. And so there's stuff that I could really try to set up a plan for growth. And so that's a long story, but why would I move south? It was because when I said nutrition prevention and health equity, it resonated with what they wanted to do here, and they recognized the need for it. So I'm loving it. It's hard work every day, but gear up and get out there. And I do clinics on the West End in the poor area, and I just do everything I can to try to improve it for as long as I can.
Yeah, so that's a really great story. I'm just curious, like when you deal with patients, patients that maybe are not all that sophisticated, lower socioeconomic status, how do they respond to the idea of improving their diet? Because these habits can become very entrenched. I mean, even affluent people struggle with the idea of improving their diet. Right. What kind of response do you get?
And so that actually is a major topic that I actually, one day out of frustration, I actually got on with ChatGPT and I said, ChatGPT, tell me if a whole food plant-based diet would decrease, according to the CDC, dietary influences of disease, number one cause of death, 80% of our healthcare budget. If a whole food plant-based diet could dramatically improve our chronic diseases and our healthcare budget, stop the animal abuses and torture and stuff, and improve our planet. Now that I got 9 grandkids, I actually care about the planet. Yeah. Why doesn't everybody do it? And it gave me 10 really good reasons. Misconceptions about nutrition adequacy, misconceptions about cost to do a plant-based diet, not realizing that you could do beans, grains, nuts, seeds in bulk, and it's cheaper than any kind of even fast food. And so they went on and on. It's culture, it's history, it's taste. Taste are formed in utero.
Yes, I've read that.
And so really good conversation. I'm actually going to go ahead and publish it, a conversation with ChatGPT on this. And yes, I live it every day. But it's good to go to clinic realizing what you're up against. And then you try to break down those barriers. And I'm having some success. And I always tease the patients. I said, if you do everything I ask, I'm going to be very happy. If you don't do the things I'm asking, we're going to make money.
That's a good way to frame it. Well, we have an acquaintance that's very overweight, has had multiple stents, is in a really kind of a bad way. And we've tried to convince him to go. We physically handed him Dr. Esselstyn's book, and it's been reluctant to adopt it. And one of the problems is, he saw his primary care provider and they said, oh, that's too much carbohydrates. That's going to cause problems with your diabetes. So I think the health system itself is an obstacle. I remember one time I'd been on call and I was tired and having a busy day. And this was during COVID, and some local vendor was out with a truck outside the hospital giving free fresh donuts to the employees. And I'd been up a good part of the night. I was kind of disinhibited, and I kind of ranted to the radiology manager, like, is this an institution of health and healing? Why are we feeding people that make them sick? You would never tolerate people smoking in the hospital.
Right.
But, Dr. Greger points out that more people die from poor nutrition than die from cigarettes now. And yet the hospitals condone this. When I used to work at Abbott Northwestern Hospital in Minneapolis, they had McDonald's there, like 100 paces away from the heart hospital. And I think one of the problems is the healthcare profession, the healthcare industry normalizes this. And so then when people like you and I get out there, oh, that's just marginal information. I mean, we're not backed up by how the healthcare system actually works.
Why is it that we were able to stop cigarette advertising in 1973, but we cannot stop fast food advertising to children? I mean, we've got some low-hanging fruit and fruit and vegetables that we could actually employ to improve our healthcare system, and it mostly revolves around nutrition. Not enough attention to prevention in this society.
That is one of my just absolute pet peeves. Now, I gather the thinking has evolved quite a bit on the longer chain omega-3s from a perspective of cardio prevention. My understanding is that the trials have not supported that supplemental longer chain omega-3 fatty acid actually don't really help. But I understand that there are some concerns that might be neuroprotective. What are your thoughts on that? Should we be taking fish oil or plant-based, algae-based omega-3s? What are your thoughts?
Definitely afraid. I'd refer everybody to the March 7th New England Journal of Medicine this past 6 months ago, where they elucidated the issues with microplastics and nanoplastics. No, we have polluted the oceans to the point where we shouldn't be eating anything that comes out of the ocean. And I was fine because I had a fish allergy, hadn't eaten fish in over 21 years, as you pointed out, but on a whole food plant-based diet. But I thought that algae-based omega-3s would be a good idea because, you have wonderful guys, smart people like Joel Furman saying that you need these omega-3s. You're absolutely spot on that in cardiology, it was thrown into disarray we had the DHA versus EPA. First of all, you take EPA by itself and it showed a tremendous benefit. And then they were called out by other ongoing trials that published and had no benefit from omega-3 fatty acids. And so that one company will say it's because you didn't get rid of the DHA. And they retort that they used corn oil as their placebo, and that trial that showed benefit used mineral oil. And that mineral oil is toxic and dyslipidemic and increased the mortality. And therefore, you set up a straw man that you beat the heck out of. That is an argument that would take large amounts of multivalent trials. That is corn oil, olive oil, mineral oil, and fish oil with and without the separation of EPA and DHA. That's what it would take to solve this. But right now, we do not have great evidence that we're cardioprotective. One of the most annoying parts of that was the idea that you could decrease atrial fibrillation with fish oil. And it turns out in the larger trials, omega-3 actually increases atrial fibrillation. So we want to avoid it. Now, is it neuroprotective? We really do need long-term well-designed trials like the one that I just described, looking at cognitive function. And I'm hoping that we get to that because I'd certainly like to keep my brain. But what it seems so far, based on Dean Ornish's published publication in September about prevention or improvement of mild cognitive impairment with a whole food plant-based diet and the whole Ornish program, it's not just diet, it's exercise and stress-free environment or lowering stress and mindfulness and the like. That data is strong enough to say that we really should be paying much closer to the animal-free diets and our exercise, all of those things decrease intracoronary plaque. So we have I think good evidence that it's stopping intracranial plaque as well, which is largely responsible for the Alzheimer's disease. Alzheimer's disease is probably just coronary disease in a different place.
Right, right. If I can backtrack, there was a question I wanted to ask you that I forgot. You mentioned getting imaging in appropriate circumstances to, look at stenosis of the left main and left anterior descending coronary artery. So if you did have narrowings there, now my understanding is that elective stenting is not terribly effective at affecting mortality rates. So would you say you did have a stenosis there? Would you just advocate more intensive statin therapy? What are your thoughts?
Okay, so let's talk about the ischemia trial. It's published 5 years ago. It was groundbreaking. The interventional cardiologists are not big fans of it because it said basically that every stent you ever put in anything that wasn't a left main or a proximal left anterior descending did not help the patient. Those two curves for the invasive group versus conservative group, medical therapy that didn't even include maximum dose statin in every person with the modern target of less than 55, because we didn't know to do that back then. And it didn't include whole food plant-based nutrition, okay? So if anything, medical therapy should be better now, if it's well-informed, than it was back then when that trial was done. And so the surgeons and the interventionalists were not big fans of it, but basically they excluded left main, and the left anterior descending was not excluded, but gave a signal toward improvement with the intervention. And that makes sense. And so what you're saying is true, that overall, you don't do a lot for stable patients. Anyone who's having a heart attack, I don't care if it's the third diagonal or the distal branch. If you're having a heart attack, there's good evidence that you have an entirely inflamed coronary tree, and every plaque is vulnerable. And so do as much revascularization as you can if you're in the middle of a heart attack. If you're not, if you're stable, probably should avoid it unless it's definitely, if it's not left main, and maybe if it's not left anterior descending. Proximal.
Yeah, okay.
Proximal.
Okay. Yeah. Okay. Well, that's really good information. Actually, we're getting low on time here. I know you have commitments. I could probably go on for quite a while longer, but I want to be respectful of your time. So we really appreciate you taking the time to do this. It's really quite an honor to talk to you and very informative. So thank you very much.
Absolutely. Definitely my pleasure. Anytime.
Okay, great. Thanks a lot.